Welcome everyone and good evening to the SAB's September educational webinar event. Before we begin, just a few reminders to our attendees. You all are currently in a listen-only mode and you're muted. We do ask and encourage you all to submit your questions for Dr. Chaudry as he presents tonight. You can do this by using your question feature. It's located on your control panel. We have Dr. Hussam Naif with us tonight. He sits on the SAB's Education and Program Committee, as well as is the SAB's Industry Relations Committee Chair. He will be this evening's moderator, and I will hand it off to him to get us started. Thank you.
Thank you, Emily. Welcome everyone to the Society of Advanced Bronchoscopy Educational Webinar Series. Your host today, Hussam Naif. We present to you on a monthly basis discussions and reviews in advanced bronchoscopy and interventional pulmonology. Today we have an exciting topic: expanding the horizon of mediastinal staging, combining EBUS and EUS. Few housekeeping items. You can post your questions in a chat box through the session. And today our speaker, Dr. Fawad Chaudry, he's an associate professor of medicine, adjunct associate professor of surgery, and the director of interventional pulmonology, unit medical director pulmonary at University of Oklahoma. Without further ado, Dr. Chaudry.
Thank you, Sam. Can you all hear me all right?
Yes.
And you can see my screen as well?
All good.
All good. Okay. All right. Thank you so much for having me. Is it time to start, Hussein?
Go ahead, Dr. Chaudry.
All right. All right. So again, my apologies. I think we could not get our camera working, but my slides are why it's not working. Yeah, but my slides are working. So there are quite a few things that I wanted to discuss regarding staging on endobronchial and endoscopic ultrasound. Some of the slides you will see will skip just because I wanted to have it as a reference, but we will talk about them, and hopefully we'll have about 10 to 15 minutes for questions. So no specific disclosures that are relevant to this talk. Objectives-wise, I'm gonna minimize these. Okay. So objectives-wise, we're gonna be basically discussing the mediastinal staging and primarily the role of combined endobronchial and endoscopic ultrasound with regard to the mediastinal staging and comparison between the two approaches and the yield, as well as some technical aspects and some staging principles and guidelines. Okay, so all right. As we know, that's where we need to focus on in terms of the lung staging with the 8th edition. Goal is to diagnose when we are in N0 and N1 stage, when the tumor is still resectable. Now, when we talk about mediastinal staging, whenever we have a tumor or a nodule, then the next phase we're going to have to look into is mediastinal staging to see if it has gone to the localized lymph nodes. And for our, is my arrow working? So this area is, I'm just going to use arrow, mediastinum, that includes level 2, 4, and 7. And then level 8 and 9 are inferior mediastinum. And of course, level 5 and 6, which are para and subaortic nodes that are also in the mediastinum. When we talk about level 10 and 11 on either side of the lungs nodes, this is hilar. Okay, and then of course 12s as well. Now, you can, if there is any technical aspects, please let me know. I'm just going to keep going otherwise. So mediastinal staging, as I just mentioned, after initial biopsy or without a biopsy, when we're considering possibility of lung cancer, you have to stage. The first part is non-invasive staging, which is CT PET, followed by invasive staging, which endoscopic, endobronchial, versus surgical, which is a thing of the past now. So going to the non-invasive staging, CT and PET are the first, as we all know. Some data about it. Consideration of lymph node positivity on the CT scan is when it is more than a centimeter. in short axis. There are varying definitions in literature, but that is generally accepted definition. This meta-analysis of 7,000 plus patients showed 55% sensitivity and 81% specificity with CT alone in terms of non-invasive staging. PET scan with SUV of more than 2.5 with this meta-analysis of more than 4,000, it showed 80% sensitivity and 88% specificity for detection of lymph node mets. So PET CT is better than CT alone, and we all know at this point, every patient who needs lung cancer staging undergoes primarily PET CT as opposed to CT. Now, this is a very good table. How do we proceed? This is from revised ESGS guidelines in 2014. If we are suspecting and we are staging, if mediastinal lymph node is negative on the CT and PET or PET CT, then when do we need to do invasive staging, which means endobronchial, endoscopic ultrasound, and biopsy? There are these criteria where we do not need to. For example, if it's a peripheral, less than 3 centimeter nodule, and patient does not have any hilar or mediastinal lymph adenopathy, then you can go straight to surgery. However, if either the tumor is central or even if it's peripheral and more than 3 centimeter in size, or if there is hilar lymph node, not mediastinal, hilar is enlarged, then we have to do tissue confirmation with PET-CT, with the invasive test, which at this time more endobronchial, endoscopic ultrasound and biopsies. And then based on the results, it's going to be either surgery or neoadjuvant chemo with surgery or other multimodality therapy. On the contrary, if PET-CT is positive on the mediastinal lymph nodes in the beginning, not hilar, mediastinal itself, either station 4 is positive or station 7 or 5 or 6 or 8 or 9, then these patients do need to undergo invasive staging. A bit of history with regard to lung cancer guidelines, how it has shifted. In 2007, chest guidelines recommended mediastinoscopy versus EBUS or EUS. In 2013, the guidelines suggested a needle-based approach on top of rather than the mediastinoscopy. Moving forward with the revised ESGS and NCCN guidelines, even later than that, they all recommended EBUS plus minus EUS as first invasive technique as opposed to either of the approaches alone. Definitely no recommendation for mediastinoscopy anymore as a first step. This slide I'm going to skip. Now, minimally invasive lung cancer staging. We talk about mediastinal lymph nodes that also involve, if we are doing endoscopic ultrasound as well, METs as well to the liver, adrenal, celiac axis that are in the range of endoscopic ultrasound. This is a picture from actual mediastinoscopy. So just a couple slides about it, and that we will discuss further. The exposure, contrary to the belief, exposure of lymph nodes with the mediastinoscopy is not as much as EBUS, and definitely not as much as EBUS plus EUS. Lymph nodes that are accessible are paratracheals, level 2s and level 4s and level 7. Rarely with an extended, you can get to hilar. Mostly hilars are not reachable. The sensitivity and specificity based on the older literature is 78 to 81% of sensitivity, and specificity is about 100%. Now, jumping on to endoscopic and endobronchial techniques, which is the main core of staging at this point, I'm going to go over some literature very systematically. There's a lot of literature out there, but I tried to put most of the relevant ones and the most cited ones. So a lot of EBUS related studies. Overall sensitivity, if you see, is ranging from 85 to 92, 95% with a specificity of 100%. With the EBUS literature 1.5 decades ago. And we all know Yosufugu is the one who invented EBUS itself. Worked with him. He's somebody with a lot of knowledge and, of course, bringing new stuff. Even now, we will talk about it as well. So, anyways, now fast forward. Subsequently, the studies were done on EBUS and negative mediastinum. What is the percentage of patients with skip METs when the CT and PET is negative with a lung nodule? So in this study by Hurt and colleagues, they took 100 patients with lymph nodes more than 1 centimeter in size, and they did mediastinal staging. And malignancy was detected in 19 out of 119 lymph node sampled with a sensitivity of 92 and a specificity of 100%. In general, with the literature, multiple studies have gone over, and the rate of skip METs with a negative mediastinum in someone with lung cancer or lung nodules is about 15 to 20%. And that is why it's important to do invasive staging in a CT PET negative mediastinum. A couple other studies, 2013 and 2015, one by Yosufugu, a very well-cited study, and second by Ong and colleagues, discovered the same principle. N2 disease was found in 6 out of 94 patients who had clinical N0 on the CT PET. And there was a downstage from N1 to N0, which means hilar lymph node were enlarged or lit up, but they were negative with invasive staging in 47 out of 67 patients. Similar results of about 22% upstaging in Ong and colleagues study. As I mentioned, anywhere between 15 to 20 to 22% is the skip METs in patients with negative mediastinum, depending on the location of the tumor, depending on the size of the tumor. So EBUS meta-analysis basically shows 88 to 93% sensitivity and specificity of 100%, and it is equivalent to mediastinoscopy, sensitivity, diagnostic accuracy, and negative predictive value. This has been in multiple studies, and that's meta-analysis also. Now, shifting gears and going towards EUS upstaging, one of the earlier studies in the earlier 2000s, most of the studies they did gastroenterologists did the endoscopic ultrasound, and in the last 10 years, we have some studies where EUSB has been used as well. So in this study, they took about 44 patients with a resectable tumor on CT scan and did endoscopic ultrasound and biopsy. And of course, they did find stage 4 disease in 7% of patients, stage 2A, 3 in 7%, and stage 2A, 2 to 3A at 4% of patients. And to their surprise, EUS FNA led to avoidance of thoracotomy in 13.6% of patients with the CT findings of a resectable tumor because of celiac access node, because of the adrenal involvement. Hence, again, as we discussed, very important to do invasive staging. Subsequently, there are some studies that I'm going to go over which show combined endoscopic and endobronchial ultrasound and the yield with that. This is a study by Hurt and colleagues that showed 160 patients with enlarged lymph nodes. They took 160 patients, and about 20 patients per group were assigned to each lymph node station, and they were basically EBUS and EUS was done for each specific lymph node in a systematic fashion. And EBUS success was 85%, EUS was 78% overall, with combined success of 97%. Another study by Willman that showed it's a prospective 33 patients with mediastinal lymphadenopathy. Total of 119 nodes were sampled, all approachable nodes through EBUS, and all approachable nodes through EUS were sampled. Overall, when they combined results, 11 additional nodes were positive by EBUS over EUS, and 12 nodes were positive by EUS over EBUS. And the reason is esophagus lies slightly to the left of trachea in the upper thirds to middle thirds, and then it goes behind. Most of the time, level 4R is extremely hard without trachea coming in between to get a biopsy off. That is why you see less sensitivity overall. Level 2R can still be difficult as well. However, the left-sided nodes in level 7 in the upper mediastinum are easier by EUS as opposed to EBUS. And then, of course, level 8 and 9 are only accessible by EUS. and level 5 and 6 only accessible by linear EUS. Then we'll talk about it, how we can access level 5 and 6. So there is a reason that if you combine both this, and if we take the Mets out in terms of adrenal and celiac axis, even then the approachability to the whole mediastinum is more with a combined approach. This is another well-cited study by Wallace and colleagues that basically they took 138 patients, and every patient they started with linear EUS, and did all the stations that could be approached by EUS. Then the patient was put back on the supine position, and then they did TVNA of the lymph nodes that can be approached that way, followed by EBUS. And then the combined sensitivity was calculated that was highest when they combined EBUS plus EUS FNA, 93%, as opposed to either of the approaches. TVNA was much lower, but either of the approaches alone was much lower, 69 and 70%. Subsequently, again, with a combined approach, some of the studies were conducted to see how it plays out in terms of yield and sensitivity and specificity in patients with a negative mediastinum. So in this patient, or in this study, basically they took 120 patients, and combined approach was done. All the stations that were accessible by EBUS and EUS. The yield by EBUS was 52, sensitivity was 52% in all stations accessible by EBUS, and EUS was 70%. However, when combined both individual modalities to a combined yield was about, yield, sensitivity was about 76% with accuracy of 93%, as opposed to 70% sensitivity with EUS and 52% with EBUS in a negative mediastinum. Again, so in a negative mediastinum as well, we have significantly higher sensitivity for these studies. Now, this is a study more recent, which was done to see how EUSB, which means interventional pulmonologists taking the EBUS scope and putting into the esophagus and staging to get the added benefit of the nodes not reachable, or the nodes which are sometimes difficult to reach by EBUS, for example, 4L, especially when it's normal size because of the trachea and distance. So how the yield and how the sensitivity and specificity in that regard. And in this patient with 150, in this study with this 150 patients, 257 lymph nodes were biopsied. With about 146 patients had a final diagnosis of non-small cell lung CA. Here, the sensitivity of EBUS and EUS FNA and combined was 52, 45, and 73% combined. So 73% was combined EBUS EUS, 45% was EUS, and 52% was EBUS. So again, combined had much higher sensitivity as well as higher negative predictive value. And as I just mentioned, it's just the fact that some of the nodes are not reachable by EBUS and some of the nodes are better reached by EUS. All right. So this is a paper from my parent institution. Just 2014 was published. Now in Montreal, we do every patient as a combined. And the way to go is first do EBUS and survey all. In routine, we go to EUS and survey all. And then in general, EBUS was used for biopsying more 4R and sometimes 7, EUS 4L and 7, and other 8 and 9 adrenals and whatever else was enlarged. So this is a study where each patient acted as its own control, because after EBUS, EUS was done, followed by mediastinoscopy, and those that needed surgery for the indication did undergo surgery, and those who did not were followed up for 6 months, for 12 months. So patients over 30 months, 166 patients with a prevalence of N2 and 3 disease of 32%. EBUS lymph node stations were 2.2, as a mean with EUS of 1.7 with combined of up to 4 stations, and then followed by mediastinoscopy with average of 3 stations. The sensitivity of EBUS was 72, EUS was 62%, and combined was 91%. And negative predictive value was 92% with accuracy of 91% with a combined EBUS EUS, as opposed to even 89% on mediastinoscopy, which was statistically non-significant but lower. Now, EBUS EUS diagnosed N2, N3, and M1 disease in 24 patients, where mediastinoscopy was negative, and it did prevent thoracotomy in 14% of patients. So this is important, the role of EUS in that, where you can save surgeries because of metastatic disease or N3. Moving on to another study by Prav and colleagues regarding combined EBUS EUS in patients with negative mediastinum. And the purpose, I'll show you why, another important highlight I wanted to share with this study. 161 patients with a biopsy proven non-small cell CA, where pre-endosonography CT and PET were negative. They did undergo EBUS EUS. 416 lymph nodes were sampled, of course. In this study, if you see endographic staging, upstage 13% of patients with radiographic normal lymph nodes. So a question has been raised in the past as well. If the mediastinum is negative, should we still consider combined? And again, I think, in my opinion, if you have expertise, definitely do. If not, even then, acquiring expertise and considering is a good idea. Although the percentage of lesions that are not reachable by EBUS is about 1.5% in this study, there were a couple of patients with adrenal and one patient with 9R involvement in a negative mediastinum. If you look at here, that had actually mets to adrenal, and of course, as N2, N3, I think it was N2 station 9 in this patient, that prevented further surgery. So it can, although the percentage in a normal mediastinum of finding 8 and 9 or adrenal, normal adrenal, or slightly enlarged adrenal is not that high, but it is there. So that is again subject to, subject to decision by the operator. But positive, for sure, any of the nodes EUS needs to be done, in my opinion, and many experts' opinion. Negative mediastinum, in my opinion, it would be better to have a full staging. But again, as I said, it is subject to discussion and no right or wrong answer. Combined EBUS EUS meta-analysis, there were two, 2013, by Zhang and colleagues, that show that EBUS EUS combined is more sensitive than either of the approach alone, as we have discussed some of these studies. And this subsequent in 2016, a total of 13 studies, very comprehensive analysis. Again, we have to take it with a grain of salt. It's a meta-analysis. But addition of EUS to EBUS increased the sensitivity by 0.12, and addition of EBUS to EUS by 0.22, based on this meta-analysis, and that is again the approachability of more lymph nodes. So I have some videos and some other things, so I'm going to skip over some of the slides. We know these ESTS, ESG, and ERS guidelines, combined guidelines, are recommending now combined EBUS EUS as a first step, as opposed to either test alone. Recommendation of at least 3 mediastinal lymph node station for lung cancer staging. So in a typical scenario, if there's a right upper, right lower, left upper, left lower lesion or nodule, 4R, 4L7 are at least needed to be done. And then subsequent, there are enlarged nodes and or Hyler nodes should be considered. Hyler does not usually change as much management as, mediastinal N1 versus N2 disease. Left adrenal gland should be, if it is enlarged, should be definitely biopsied, because this is a common occurrence of METs and definitely indication for EUS. Even if there is no expertise in that institution, that should be sent to a gastroenterologist for adrenal, for metastatic disease before definitive decision. And then recommendation is to have individual endoscopists should be trained in both EBUS EUS in order to perform complete endoscopic staging in one session and endobronchial as well. I'm going to skip over morbidity. Really, all the studies from the EBUS EUS perspective did not show much complications. Technical aspects, we will skip over. We all know a lot of literature out there, how many passes, suction, no suction, and if questions are there, I can answer them. I think it's now. This is the basically I wanted to explain a few things here. We can see PA aorta. This is the mediastinum, and basically, if you combine EBUS and EUS, most of the stations can be reached. As much as wax, much more than mediastinotomy or mediastinoscopy. And the next chart will show it very clearly. This is a very good chart, takeaway from this talk. If you look at EBUS, you can reach level 2, level 3, level 4, 10 and 11, which are higher, and level 7. With EUS, you can, of course, reach level 3, level 4s, especially 4L. But in addition, you can also reach level 5 and 6 and level 8 and 9. So 5, 6, 8, and 9, and literature has shown that 4L and 7 has higher yield to EUS as opposed to EBUS. Even you can always reach 7 through EBUS, but sometimes because of the cartilage with a normal size node, you don't get a good yield. But with EUS, no cartilage in between, you always get a lymph node. So the approach to all the mediastinum is as much as wax with EBUS EUS combined, especially if there is access to 5 and 6 is available. Okay. Now I'm gonna then jump on how can we biopsy level 6 or level 5, and I'm gonna share some examples. This is a study done by Moish Lieberman, how we can go above the arch of the aorta next to the subclavian, and then change direction once into the mediastinum to enter the level 6. So they did a study of biopsying level 6 without reversing the aorta, and out of 274 combined cases, 4.4% patients did undergo this biopsy, and follow-up at 30 days was done. And if you look at here, the needle is coming out here. This is arch of aorta, and this is level 6. And this is how just proximal to the arch of aorta with a slight change in direction with the EUS linear, because you can change the liver with the direction, you can access that. And this graphic representation is not working. So in their study, their accuracy and sensitivity was 100%, and 2 eligible patients were not biopsied, no morbidity and no mortality at 30 days. So this is an example. Now, moving on to the next study, this is a study done by myself and my colleague. So this is the only large study in the literature regarding transvascular, transaortic, and trans-PA biopsies of lymph nodes when it is needed. There are some other series which, I think a total of 7 other series are there. They are mostly under 10 patients, but there is some other evidence as well in the literature. But this is the only one with more than 20 patients. So 100 patients, the transvascular EBUS or endoscopic guided biopsy. Under EUS guidance, 65 patients, and EBUS at 35 patients. Target was mediastinum in 60 patients. Aorta was the vessel most commonly traversed with N of 57, with PA 33. Median of 2 passes with a 22 gauge and a few with 25 gauge needle. Samples were adequate in 80 patients, and this whole study duration, there was no Rose availability. So despite that, the sensitivity of transvascular biopsy was 71.5 with accuracy of 74.5%, and that was followed, most of these patients were followed by surgery as well, who were negative. There were no observed intra-op or immediate post-op complications. So this is the evidence. We published it in 2021. So if you look at here, there are some other studies I talked about. The most traversed vessel was aorta, followed by pulmonary artery. And the complications, there was one complication, patient, it's written in the paper, got readmitted after 3 weeks of biopsy. All these patients were followed up to 18 months. This patient was admitted with bilateral pneumonia. And in the repeat CT scan, there was pseudoaneurysm of aorta. On further questioning, which was not known at the time of biopsy, patient had a tertiary syphilis and had severe aortic stenosis prior to the biopsy. So maybe in that patient with that history, we could have avoided doing, but there was no clear-cut evidence of any, post-op complications. Nonetheless, this was considered as one potential complication out of these 100 patients. So this is a graphic representation of some of the biopsies that we did. You can see this is EUS linear, this is aorta, this is PA, and this is level 6 lymph node, and biopsies being done. Once you traverse the vessel wall, both walls, then you get inside the node, but remember, we just stay in the node and do not change the direction. So basically one in and one out from the vessel itself, and then multiple agitations in the node. So this is a case that I did in OU about a year or so ago. This patient had, if you see, same thing, just a bad video. Aorta, this is a level 6, and this is my needle coming, and this is EUS linear. So importantly, this patient had a left upper lobe. Now with guidelines, you know that if there's a left upper lobe nodule and level 5 and 6 are enlarged, then they have to be biopsied. So exactly the same book picture. This patient's whole mediastinum was negative. And then he was referred to me for biopsy of level 6, which was about 2 centimeters in size. And I did the biopsy and turned out to be a small cell. So this transvascular biopsy, patient had no complication, did save the patient from any big surgery / VATS, and got started on treatment. Now this is another example of where the benefit of transvascular in occasional patients. This biopsy I did within the last 2 weeks, and I think it's on LinkedIn as well. This patient was basically asked by all the various thoracic surgery. Everybody refused GI, thoracic surgery, interventional GI. So this is his lesion. It looked like it's inside the aorta, but if you look at here, it's juxta-aortic. And in this coronals, if you see, this is the lesion. So they called me and they asked me that if I can, because patient was younger in 50s, and there was no way anybody was touching him. So if you look at here, this is the aorta, and this is just the picture taken from phone. Is not. This is the lesion, just like here, if you can. So I did biopsy that, and it turned out to be lymphoma. And patient is undergoing treatment now with his oncologist. So again, the percentage of transvascular biopsies, I'm by no means saying that we should just go through aorta right and left. It's about 2%. In the study that we did, we had about 2.5% of patients that required. And in my practice, it's hardly more than 2 to 4% where we had to traverse really from aorta and PA in the esophagus. Occasionally, a vessel, and I think it's a common practice, we all know who do enough EBUS, that vessels get punctured, nothing happens. While going through the hilum, sometimes they can be punctured. Also, there are some masses which are approachable through PA, and if there is no other way, and if that benefits, that can be done. However, that is not a preferred route if you can get it done without traversing any vessel. All right, so very quickly, I'm gonna, because I think we are getting to the end. Other benefits of EUS. This is a paper recently published in the last couple of years. Biopsy of masses, central lung masses that can be approached to esophagus. Really, out of 47 patients, the accuracy was very high with these patients when they used the coring needle, as opposed to FNA, 78 versus 100%. So really, most of these nodules were biopsied, and they were successful because you're really seeing it live, real time. An example, this is a right lower lobe lesion. This is esophagus, and it is very easily approachable. A couple sections below, and you can just go right into it. there is not going to be any chance of pneumothorax as long as your needle is inside the lesion. Now this is a left upper lobe lesion, and look at that, how good it's visible through EUS, and biopsy showed malignancy. Scopes wise, we know this is EBUS, bronchoscope, this is linear EUS. You have to have training for that because most perforations happen because of it if it's not done rightly. This is radial EUS. We don't use it. We use it during our training because of esophageal cancer workup as well that we used to do. So moving on, I'm going to spend about 4 to 5 minutes showing some slides of how the lymph nodes appear on the vascular anatomy, and then we'll leave 10 minutes, 5 to 7 minutes, and then we'll leave 10 to 12 minutes for questions. So this is level 2L, and you can see aorta and left subclavian artery lateral to the node. So this is seen from EUS. 2R station with innominate vein distal to the with the blue arrow. So this is 2R from EUS. 3P we can approach, it's anterior to the esophagus and posterior to the trachea, so approach both ways. This is a book picture, right, of 4L, aorta, PA, and 4L. This is the ligament, pulmonary ligament, and then this is 5, beyond ligament of Brights. So 4 and 5. And this is biopsy, one of the biopsies that I was doing, aorta, PA, and this is the needle going in. 4R, typical book picture. This is approachable through trachea. Very hard to approach from esophagus. So EUS is not good in 4R at all. I never even tried. So above SPC, and primarily this is the picture you want to see for 4R, and it should be proximal to EBUS. Now this is, you can see aorta, PA, and then lymph nodes. So vascular anatomy is what is needed for EUS. 5 structures that need to know is where is left lobe of liver, then abdominal aorta, celiac axis, and then moving up, right atrium, left atrium, PA, and aorta. So between PA and left atrium is this way, is level 7, PA and aorta, level 5 and level 4. Okay, so another picture of level 6, level 5, aorta, PA, level 5 lymph node, aorta, PA. And this is level 7, as we all know, with just above the left atrium from the EBUS. Let me show you how it looks from esophagus. So as I just mentioned, upper part of the left atrium, PA, and this is level 7. If we pull back and look to the left, then we'll find 4L. So before PA will be aorta. So vascular anatomy, once you know that, it's very easy to do EUS. Level 8L, which is not seen through EBUS. Level 8R, again, not seen from EBUS, only from EUS. Level 9R, sorry, this is 9L with a reflection of pleura. Just below 9L is celiac axis node. This is at the diaphragm. 10L, we all know how it looks. Level 10R, again, this is a big 11L lymph node, and you can see branch of pulmonary artery beyond it. Okay, this is 11R, 12s, maybe more important when we go segmentectomy more. Celiac axis, so abdominal aorta, then gives us celiac trunk and celiac axis node. It's a metastatic node. That is one of the things that we survey when we do EUS. If you look at here, this is liver, this is portal vein, and this is gastrohepatic ligament, lymph node enlarged. Again, this positive lymph node is consistent with metastatic disease. This is liver mass. Left lobe of liver, we routinely biopsy those through EUS, very easily biopsyable, again, metastatic disease. This is very, very enlarged, almost completely taken off left adrenal. So this is a metastatic disease. We need to puncture it, and it just turned out to be metastatic disease. This is left kidney. So conclusion and pearls, basically 8th edition TNM, EBUS EUS need to be is superior to PET-CT, recommend needle-based approach, recommend EBUS EUS as opposed to either of the approach alone if expertise is available. This is the punchline. Additional benefits of EUS in station 8, 9, 5, 6, celiac axis and left adrenal. This cannot be done through EBUS. If these are enlarged, definitely EUS has to be done. And debate, is still on whether with a negative mediastinum every patient needs a combined or EBUS will be, sufficient. Which again, I think both sides of the coin out there. This is the last slide of my daughter. And then,
Daddy, my mom hurts, my tummy hurts, my arm hurts, my legs hurt, and my ears hurt, and my head, and my neck.
so that is complex problem she has. So we have complex problems. So we have to have more tools for that, right? So that is it for me, and I'm happy to take questions. And again, I apologize for the video issue.
Thank you so much, Fawad. This was very comprehensive and well thought out presentation. It's an interesting topic for sure. First question, do you have size / morphology criteria for which lesions you don't biopsy? I'm assuming for both EBUS and EUS.
So good question. You know that we have 5 millimeter with the guidelines. Any node which is 5 millimeter and above needs to be biopsied in a negative mediastinum. So really, when we are staging, I hit at least 3 mediastinal stations. Even if it's very hard to measure difference between 3 and 5 millimeter. So anything that I can see, we hit it. If it is enlarged, definitely we have to biopsy it. So yeah, for for simplicity, at least 5 millimeter and above, all stations should be biopsied. All meaning 3 mediastinal. We don't need to go for a 5 millimeter hilar node, ipsilateral hilar, if it is not changing the management.
I see. A question from myself. So how does the learning curve look like? And the other thing is, you had the opportunity to train on this for fellowship, but for current providers who are not trained on EUS or EUSB, I mean, does partnership with GI or advanced endoscopy and how's that looking like? I mean, is it something you can learn or you need a lot of experience in handling those type of cases? Obviously, operator is an EBUS, expert or if proficient.
Excellent question, and I think this question has been asked before as well. In fact, I had a podcast about 1.5 years, and that was the main discussion there. I think jury is still out. I can give some. Number one, it is very learnable. All of the advanced bronchoscopists like yourself are very skilled, and I think nothing is beyond learning. First, I'll talk about EUSB. I think EUSB learning curve will be smaller because you just have to intubate the esophagus with a scope that you're used to and learn the vascular structure. EUS linear will be much bigger learning curve. Now, there are few studies out there. We know that EBUS is a soft guideline for 50 patients for EBUS. EUS, they had 150 EUS for interventional GI in one of the studies that I went through but then even with 150 linear EUSs, it was ultimately that it's all operator dependent. So you may not. So even it's a much higher learning curve for EUS linear. Then there were a couple small studies where they did interventional pulmonologists with EUSB, and the learning curve was closer to 20 patients. And then when they followed up, there was this one study that 20 is not enough. So is it 20? Is it 50? Is it 150? We don't know. What we know is it is operator dependent. There has to be some sort of a learning to start with a model, and then some supervised procedures on the patients under expert. My personal opinion is I think EUSB, based on the literature, we have EBUS 50, at least 50 EUSB, and then maybe some under proctoring should be enough for a good interventional or advanced bronchoscopist. Maybe less than that. I think it all depends how quickly we learn to navigate into esophagus. For us, as you said, we had a unique opportunity where we did as much EUS linear and EGDs because of the thoracic surgery program as EBUS. So we came out doing 500 plus EUSs. So I think it was a unique opportunity, but very, this is something that we as an institution, as advanced bronchoscopists and interventionalists, hopefully will need to promote and get more, learning on board here. But I think a good proceduralist, I think a very good proceduralist should be good after 20, and slightly less skilled, maybe 50 for EUSB.
Yeah, awesome. Second question. Thank you for the great presentation, Dr. Chaudry. What are the current recommendations for number of needle passes during EBUS TBNA to optimize diagnostic yield in the radiographically normal lymph node? You can say probably 5, but I'll take your answer, Dr. Chaudry.
Yeah, I think it's as we know, the yield plateaus after 4. So
Yeah.
that is what we have. So I would stick with that, and that is what. So we have, again, most of those studies were done, and the 4 passes study with real experts of interventional pulmonary at that time. So I think it again depends, and that was done without rows, right? If you don't have rows, occasionally when we don't have, I don't go more than 5 passes. 1 with suction, 4 without suction. Again, literature is clear. There is no difference between suctioning and no suctioning. That is all of us, kind of make our own methods. I got trained away, so the first one without, and then if there is not enough specimen, I'll go with suction. If there is more blood, I'll go without suction. So yeah, I would say no need to go above 4 or at maximum 5. And if you have rows, then sometimes I just do 2 passes, right? 1 pass, by the time they tell me, oh, you have lymph node, the second pass goes into the cell block and we move on to the next station. So
yeah, I mean, unless you're looking for molecular and PD-L1, then you either do a forceps or you go to town with the needle. But yeah, the suction part, that's actually, I've been to different institutions and you will be shocked what people do and consider to be the method of choice. But capillary pull, no suction, no suction with a syringe on, closed off. It's a lot of no ones there. But yeah, I agree with you. I think that first pass I try to do without suction, especially because a rose is available, and because it just basically they come back with like blood, so you just wasted the sample. So third question I have, any experience doing EUS/transesophageal cryobiopsy, especially for suspected lymphoma? Interesting question.
Excellent question. Can I ask who asked this question?
I'll find out. So once you answer.
This is such a good question because and again, as you know, that I recently, in the last 1 year or so, I did not, applied the cryobiopsy of the lymph nodes because I thought I'm getting most of the answers with the 19 gauge needle. If I don't, I go to esophagus. But then there were some tough cases, infection and lymphoma.
Non-malignant.
Yeah, non-malignant. And I really started doing this 1.1 cryo. Now I do sort of routinely 1.1 cryo, and it both, without 19 gauge and even 21 gauge, it's just such a good cryo probe that it penetrates well. I have not had the guts to go into esophagus and do that yet. And there are two reasons.
Transvascular.
Yeah, no, exactly. Even because here's the thing, we have a trachea which is very stiff, and you make a hole and you somehow get into that hole and get into the lymph node. Esophagus is soft, you're not seeing anything, so you're purely, and you cannot, kind of locate or push your scope into something. It's a muscle. So I think we're gonna do a lot of damage trying to get into the node through the esophagus, and then a little movement will kind of tear part of the esophagus, So I'm not sure if anybody would do that. And I thought about it in tough. I was like, no way. And I don't think so. There is any literature, at least that I have seen. I would be amazed to see if somebody does it. Maybe there are some people out there that do it. Yeah, I have not done it, but I've thought about it. But excellent question. I've thought about it a few times. Yeah.
Brian Rosenberg is the
Oh,
question.
okay.
The person asked question. Yeah, I totally agree. I think, if you talk to most of advanced endoscopists, the one thing that they tell you that is physiologically different is that the esophagus does not like multiple penetrations like we do in the trachea. And I think that speaks of the different structure of the wall itself, and like you were saying. And I think it may not really tolerate and may end up, creating a fistula if you really tunnel that aggressively. So, I think it still is a territory that is uncharted. And I think even for EBUS, like EBUS cryo is kind of gaining some popularity, but there is really no data. And I think that's a great area for retrospective and prospective research. So
Agreed. Yeah, I completely.
absolutely.
We are getting good results, and and that's where the data needs to be.
What is your technique? Do you tunnel with a 21 or do you pass it through a 19 gauge?
What was that? Or
For the cryo, or do you pass it through a 19 gauge?
so I've done both. Lately, I'm just not even doing 19. If I've made few passes, it goes easily.
It's easier than forceps because it's a little stiffer.
100%, much easier than forceps. And I actually have stopped using forceps. I kind of go with the cryo directly now because I think it penetrates better. In the hilum, I can tell you that I feel that just not even going into the same hole, it also goes if you just push it properly against. So the cryo probe, I think that the stiffness and the narrowing of the cryo helps, even if you're very just close to your original holes, So 19
no complications noted in your, because also there's not a lot of safety data on EBUS cryo.
And yeah, you're right. And you worry that you're gonna
cause something.
Exactly. Even 5-6 seconds of freeze I've done with about 5 millimeter of pieces, and I've gone in quickly that okay, I'm gonna be stopping to bleed, and I see it. It's as much bleeding as 19 gauge, just a little, and then you switch in. So really, I mean, anecdotally, not bad, not bad.
Not bad. Okay. Yeah, I think, for de novo lymphoma, the data is very poor, I think,
Very
for
poor.
TBNA, 60%, 50%, 55, 60,
Yes,
something
relapse
like that.
above 80%, relapse is above 85. I think the last paper I saw was about 80 to 85, small study. But you're so right, de novo was about 55 or 60% because
And
it is so hard.
sarcoid, you're lucky if you see some granulomas, but mostly it's actually the forceps that gives you better answer. Now I think cryo would be the last thing. So we have last question for the session today. How many agitations on average per biopsy do you find yourself performing with each pass on EBUS? My answer to that question is how many the attending wants, but I'll take your answer, Dr. Chaudry.
Oh, that is a good one. And I can tell you, it's a very common question. I asked when I went to fellowship, so I asked Moish Lieberman, is my mentor. I asked him the same thing. His answer was when your hand gets tired, right? So this is, and then I went to do a small course for a day to in Toronto with Yosufugu and his colleague, and they were completely different. They will just make 2-3 passes, 2-3 agitations.
Wow, agitation, wow.
Yeah. So as opposed to me, I make at
15.
least closer to 10.
Yeah.
So yeah. So I'm still married with this idea when your hand gets tired.
Yeah.
I think the important part is how you do it. You need the needle inside, and then the thing that helps the most, think of it cutting.
Scanning.
Your downstroke should be fast, right? So you're cutting it. Upstroke should be okay. So I think as long as you're making at least 3 to 5 agitations with a sharp downstroke, meaning cutting the node with a needle, and seeing the needle moving, not the lymph node, that's probably is going to be your answer there.
Yeah, and maybe add a little bit fanning to it might give you a little bit more
Yes.
bandwidth. Okay, awesome. Well, thank you so much, Dr. Chaudry. It's an exciting topic, a great conversation. For our audience, we are going to try and convince Dr. Chaudry to get this session on a podcast with Dr. Pepper. So look forward to that. And for whoever's coming to CHEST, make sure you stop by at our booth and our talk on Monday, October 7th at the Alfred Boston Seaport District Hotel. We have an exciting topic about going back to the basics of bronchoscopy. So Dr. Mercado, Dr. Hovda, and myself will be there. So looking forward to see everyone, and you have a blessed night.
Thank you. Thank you, Sam.